Hi, I'm Skye. I'm a stroke nurse practitioner at the Royal Melbourne Hospital, and I'm here to talk to you today on stroke. My background is intensive care and emergency for a number of years, and for the last 10 years I've been working in stroke either in a clinical nurse consultant role, and currently I coordinate the Melbourne Mobile Stroke Unit, which will be another talk available on Ausmed, so please have a look at that. So we're going to talk about what is stroke today. So the things that we're going to go through is just a little bit of facts and figures around stroke. What is stroke? What are the types of strokes? Look at haemorrhagic versus ischemic, and then our stroke risk factors, because that's really important when we're trying to educate our patients. Now, in this presentation are some pictures that have been taken during autopsies. So some people may find it distressing and may want to look away from the screen, but they have been chosen because they actually help show the anatomy really well and helps with the understanding of where the conditions are and how they affect the brain. So stroke is a national emergency. So currently in Australia, we have somebody has a stroke about every 9 minutes. If nothing is done to stop that though, in 2050, we're looking at one person having a stroke every 4 minutes. So it's a huge health crisis. So it's really important that we have really good, robust systems in place to care for stroke patients, that we educate the public on what is a stroke, and we get primary prevention in place to stop them happening in the first place. So while stroke currently is not necessarily a big part of a lot of nurses, paramedics and doctors' lives, it's fairly small when compared to all the other health diseases that are around. In our nursing time, we're going to see a lot more patients coming into hospital with stroke. So we need to really understand it and do something about it. So because of that number, so we're having about 60,000 strokes per year, which is just way too many. So stroke is the second largest cause of death in Australia, and it is a leading cause of disability, and that's the biggest problem. Research tells us that patients, when asked would they rather be left with disability, most of them would actually prefer to die. So if given the choice between death and permanent disability, most people would choose death. So the level of disability that stroke can leave patients with is just devastating. Once somebody has a stroke, about a fifth of our patients die within about a month, a third die within 12 months, a third are left with permanent disability, and only a third actually recover completely with no disability, which are really poor odds. And it's costing us billions of dollars currently in healthcare costs. And if that number keeps going up, it's only going to cost us more. So what is a stroke? Stroke is an acute loss of brain functioning. So the symptoms typically last longer than 24 hours. So if you are familiar with the definition of a TIA, or a transient ischemic attack, usually that's symptoms that last less than 24 hours. So stroke is generally considered over that 24-hour period. And it's caused by either an occlusion to your blood vessel, so something's blocked flow of blood down one of the blood vessels, or it's caused by one of those blood vessels bursting or leaking into the brain. But regardless of the cause, the end result is that blood supply is no longer getting to an area of the brain that it should be, and we get death of brain tissue as a result. So within stroke, we have two types. We have our occlusion type stroke, which is our ischemic stroke. This accounts for about 80% of all strokes that we see here in Australia. The other type of stroke is our haemorrhagic stroke, or our bleed type stroke, which is about 20% of our stroke presentations. Some Eastern countries, Asian countries, for example, the haemorrhagic stroke rate is in fact higher. Within our ischemic strokes, it's divided into two different types of strokes. We have thrombotic and we have embolic. And within our haemorrhagic strokes, we have subarachnoid and intracerebral. So we're going to talk about haemorrhagic strokes first. They're the smallest component, so we'll spend a little bit of time on that, but talk mostly about ischemic strokes because they're the strokes that we're more likely to see. So an intracerebral hemorrhage can also be called an interparenchymal hemorrhage, or an IPH. So it just means that there's bleeding within the brain tissue itself. So the reason that this causes damage is through a number of different factors. One is that you're stopping flow going down that blood vessel, and you're stopping it getting to where it should. You're not getting oxygen, you're not getting nutrients, you're going into anaerobic metabolism. But because the blood is now seeping into the brain tissue, it's forming essentially a space-occupying lesion, and that area, that hematoma in the brain, has a compression effect. So you start to have compression of the surrounding tissues, and you get a lot of edema then that surrounds that hematoma, which then further compresses tissue. So you have direct neuronal injury from that. And unfortunately, unconsciousness, coning, death are commonly associated with interparenchymal or intracerebral hemorrhages. So here are some photos. So this is an interparenchymal or intracerebral hemorrhage. So you can see that you have blood directly in those brain tissues themselves. So it's taking up a lot of space. And if you actually have a look at the midline of that brain, you can see that the images where the blood is, the brain is actually bowed and it's taking up area now and it's compressing that other side of the brain. So it has the amount of edema and the amount of that size of that hematoma compresses and pushes other brain structures to one side. On CT, blood looks white. So you've got the very bright white of the skull, and then in the middle of the brain, you've got this white dot. Now, if you look very closely and the contrast on your computer screen is correct, you'll see that there's a little ring of darkness around that white, and that's your area of edema. So you can see that the actual area is bigger than that white blob. You've got to take into account that edema as well as to the size of the damage that's being done. Now, that first image is a fairly small hemorrhage. Second image obviously is a much, much larger hemorrhage. So for this one, you can actually see, and I should actually stop here and say that when we're looking at CT scans, you're standing at the patient's feet, looking towards the top of their head. So the images are reversed. So as I'm looking at it, I'm looking at the right-hand side, and this is the left-hand side for how I'm looking at the patient's brain, because I'm looking from their feet up. So in that second image, they've got a bleed in the right-hand side of their brain, and you can actually see that it's actually compressed and moved into the ventricle. So we've now got an intraventricular extension, and you can see that that midline is really quite bowed. So all of that right side of the brain is now pushing over into the left-hand side of the brain. So we have midline shift. So subarachnoid hemorrhage, slightly different. So very typically associated with patients that have a sudden onset of headache. Now, if they are well enough and you can ask them questions, sometimes they'll actually report warning headaches that have happened beforehand. So they may have had really bad headaches, the last day or two, but they've gone away or they've managed to put up with them. And then all of a sudden, what they describe is often referred to as a thunderclap headache. And if patients can describe it, they will describe it like being hit on the head with a baseball bat. It is this sudden, explosive headache. So very, very quick onset. Unlike, say, maybe a migraine that builds slowly. This is bam, they've got the worst headache of their life. Subarachnoid hemorrhages are very commonly associated with a rapid fall in consciousness, very commonly associated with nausea and vomiting, and you can still get stroke symptoms. So they may still have hemiparesis, they can have facial droops, they can have speech difficulties as well. They can have other meningeal signs. And what we mean by meningeal signs is if you think back to your vascular anatomy and physiology, you have your CSF floats in your subarachnoid space. So you've got your dura mater, you've got your arachnoid mater and your pia mater. And between your arachnoid mater and your pia mater is your subarachnoid space, which has CSF in it. So subarachnoid hemorrhage, the vessels that are within that subarachnoid space are leaking and you've now got blood in that area. So your pia mater and your arachnoid mater are being irritated by blood. Blood should not be in there, and blood's a very strong irritant factor. So if you think about a patient with, say, meningitis, what does a patient with meningitis look like? They usually got a whopping headache, they're photophobic, they're phonophobic, they've got stiff neck. So all of these things can happen with subarachnoid hemorrhage as well. Typical causes of subarachnoid hemorrhages are burst aneurysms or AVMs or arterial venous malformations or trauma. So another photo. So unlike the previous photos, you can see here that the blood is sitting on that surface of the brain. So again, thinking back to your anatomy, your pia mater is your final meninge, and it's concurrent with the folds of the brain. Above that is your arachnoid mater. So your subarachnoid hemorrhage is between those two. So because the pia mater follows all the folds in the brain, the blood that's in the subarachnoid space will look like it's basically washing over the surface of the brain. So you can see that it's sitting on the top there, and the whole brain is covered basically because it's circulating through that subarachnoid space. So just a little diagram to reorientate you to those areas. So your arachnoid mater is a very fine spider web-like structure full of little filaments called trabeculae that anchor it to the pia mater. And within that are your blood vessels. So if you burst one of those blood vessels through either, as I said, aneurysm, AVM, trauma, etc., then blood is free flowing in that area that is normally filled with CSF. So everywhere that CSF is tracking, you've now got blood tracking as well. So this is what it looks like. So the top picture here, you can see that you've got subarachnoid space. It's a nice big wide space. You've got blood vessels in it, and it should be clear because you've got CSF in it, which looks like water. If you put blood, or in the case of this picture, it's demonstrating meningitis. So in this case, it's pus basically within that space. It's interfacing with your pia mater and your arachnoid mater and irritating it, which is why you get those meningeal signs, so stiff neck, headache, etc. as well. So on if you look at the brain on a CT or diagram, you can see that because the blood is within that subarachnoid space, as I said, everywhere that CSF would flow, you'll start to see blood. So it tracks, it looks like it's going into the brain, but it's actually only within that those sulci. So here are some images of patient scans that have subarachnoid hemorrhages. Now, sometimes they can be really, really difficult to see because you may have just a leaky vessel somewhere and you've just got a really fine amount of blood. So the first image on the left, you'll see the red and the white arrows are pointing to areas that are just slightly whiter than the brain matter that you can see there. So as I said before, white in CT, blood is white. So there's just these fluffy areas of whiteness in those sulci where that blood's traveling, but there's not a lot of it, so it can be very difficult to miss. The middle picture is a little bit more obvious. You can see that there's white tracking all the way. Right in the middle of that middle picture is a really bright blob of white, and you've got two black ventricles down the bottom with blobs of white. They're actually just calcifications, which can happen normally in the brain. And if you actually have a look, those blobs of white are very similar in colour intensity to the skull. So they are, if you think about calcified areas, it's hard like bone, it's absorbing more of the x-rays, whereas the blood you can see is a lighter white. So you can differentiate between those calcium deposits and the blood, but you can see that the blood is tracked all through that subarachnoid space. The final picture on the right, you can see really obvious. So, significant amount of blood. So that person has got a massive subarachnoid hemorrhage, and the outcome is potentially very, very poor. So we talked about cause and we talked about aneurysms and AVM. So just super quickly, in case you're not as familiar. So an aneurysm is a ballooning or an outpouching of a blood vessel. So the outer lumen of the blood vessel gets really weak, and it's like you've blown up a balloon. So where you've got your blood vessel, you've now got this area of wall that should only be, super small, has ballooned out. And if you think of a kid's party balloon, when it's deflated, the rubber's quite thick and tough, but you blow it up and it just has to brush against something the wrong way and it pops. So same thing, you're taking an area of blood vessel that should be really small and making it big so it's super stretched. So it doesn't take much to burst those. An AVM is slightly different. It's so normal vasculature is that you have your arteries that go into arterioles, that go into your capillaries, that go into your venules, that then go into your veins. And you move from a high pressure system to a low pressure system through that dampening down of those vessels. An AVM is where the artery essentially directly feeds into the vein. So your veins are low pressure systems and they're not designed to take the pressure of an artery. You think about a patient's normal blood pressure. If you're dealing with an older patient, hypertensive, you might be looking at 180 or 90 sort of blood pressure. You stick that on a vein, it's going to very much dilate that vein up and again, make it very, very weak. And you get this tangle of blood vessels that are under enormous pressure. So again, very prone to bursting. We're just going to spend 1 second talking about subdural hemorrhages because they are often considered stroke, but they are in fact not technically stroke. They are caused by venous bleeds. So you have veins running in your subdural space. It's usually only as a matter of trauma, so head knock, head hit, fall. It's not a primary stroke cause, it's a traumatic cause, and it's venous, not arterial. Regardless though, they can present exactly the same as a stroke because you've got now this pocket of blood in that subdural space under that dura mater. You can get significant brain compression, which then can give you, usually it's unilateral, it can give you symptoms that look like a stroke. So while it's not technically a stroke, it can look like a stroke, and this is where we need CT scans or MRI scans to show us exactly what's going on. So TIAs we mentioned before. So traditionally the definition of a TIA or a transient ischemic attack are focal neurological symptoms like a stroke that last less than 24 hours. So if you think about heart conditions, you've got patients who have angina, you've got patients who have heart attacks. A TIA is an angina compared to a heart attack. So you've got something that's gone wrong. It's caused an imbalance of your oxygen supply and demand to your brain. You've produced neurological symptoms as a result of falling supply, but it's got better. So you've not got any permanent damage. The symptoms is resolved once the blood supply has been restored. So it's a really big warning sign though to say that something's going wrong. Now, this was always the definition that we used. However, we scan a lot more patients than we did even 10 years ago, certainly 20 years ago, and we're using a lot more MRIs. So we often find patients may present, and we call them a TIA because 3 hours down the track, their symptoms have completely resolved, but you put them in the scanner and you can actually see that they've had an infarct. So those patients are stroke. So time alone is not specific enough. So while the definition remains the same, most places from a practicality perspective have adopted a definition of symptoms less than 24 hours and normal imaging. So we've had a look and we can't see any areas of stroke. We're happy to call this a TIA. So as I said, warning signs, something's gone wrong. You've reduced your oxygen supply. You've had a neurological event, but it's resolved itself before there could be permanent damage. But because something's gone wrong, TIAs are as important as strokes in diagnosing, finding the cause and starting secondary prevention, because these patients are walking time bombs waiting for a stroke to happen. So if you've had a TIA, 5% of patients will come back within 48 hours and have had an actual stroke, and 12% will have had a stroke within 30 days. So really important to find the cause. Patients often will go, I don't need to go to hospital because it's resolved. They do, we still need to find out the why. Some places still use the ABCD square or ABCD2 tool to assess TIAs. This is really a tool that's designed to say, somebody presents to the emergency department, they've had a TIA, do I need to admit them or can they go home? What's the best option for them? And it's a score that's designed to say whether they're high risk or low risk of having a stroke, essentially. So patients with high risk should be admitted. Patients with low risk can probably go home and follow up with their GP. So A is for age if they're greater than less or 60. B is blood pressure on admission if they're hypertensive. C is clinical features. So if they've got weakness versus speech versus other non-specific sort of sensory disturbance. The first D is duration of symptoms, whether it lasted less than 10 minutes, less than an hour, or has gone on between 1 and 24 hours. And your second D is diabetes. Now, one of the things that, one of the detractors of this score is that a lot of people feel it should be A squared as well, because one of the biggest risk factors for stroke is atrial fibrillation that this doesn't pick up. So if you have somebody who otherwise scores low in this score but has uncontrolled AF who is not anticoagulated, huge risk of stroke. So a lot of places no longer use this and just assess the patient holistically in totality and then make a decision, but you will still see this around. All right, we're going to move on to ischemic strokes. These, as I said, are the strokes that we're going to see most often in our clinical profession. So ischemic strokes are caused by a blockage to our blood supply to our brain, which means that distal flow is cut off. The area of brain affected depends on the size of the vessel affected. So obviously, if you've got a clot that takes up your big middle cerebral artery, for example, it's going to affect the entire hemisphere of your brain. And so that's a massive area of brain. If you block off one of the really small perforating vessels off one of these arteries, you might have a stroke that's super small. So it really just depends on the size of that artery. Within our ischemic stroke, we then have thrombotic and embolic strokes as our cause. So a thrombotic stroke is caused by an atherosclerotic plaque, the same as what you get with heart attacks. So you've got a fat buildup in the lumen of your vessels, which narrows that internal vessel down. Something happens that causes that plaque cap to rupture. The body immediately then sends platelets out to form a clot to stop that rupture from bleeding, which then means your already narrowed vessel is now nicely plugged off by this thrombus that's sitting on top. It's doing the right thing, but it's actually making the condition worse. Very, very commonly, we see thrombotic strokes from internal carotid artery occlusions. So patients with, diabetes, cholesterol, high blood pressure, etc., very common to look at internal carotid artery occlusions. So we always do neck vessel imaging in our stroke patients, either Doppler or CT or MR, to have a look at the integrity. So these are patients who may need to go on to have a carotid endarterectomy, start antiplatelet therapy, lower their blood pressure, cholesterol, etc. Embolic strokes, on the other hand, are mobile clots. So they may have come from the thrombus on your atherosclerotic plaque, or they've come from somewhere else, say from AF, or a patent foramen ovale has caused a clot that's come up from your venous system to cross into your arterial system and goes to the brain. So it's basically a clot that's on the move, and it travels until it reaches a blood vessel that it can't travel down, and it's plugged that blood vessel. So PFOs, or patent foramen ovales, is something that we need to consider. So when babies are in utero, they have a PFO, which basically means they've got a hole in the heart and you get blood flow mixing from left to right and vice versa. When we're born, that's usually closed, which then allows us to have blood coming into the right side of the heart from the body, goes up into the lungs to get oxygenated and drop off carbon dioxide, and then comes back as arterial blood into our left side of our heart and then gets pumped out to the rest of our body. If you have a PFO or a patent foramen ovale, it means that blood that's coming in from the veins in the venous system comes into the right side of the heart, can move immediately, cross into the left side of the heart and get ejected out of the aorta. So someone who has a DVT, for example, or another venous clot, it can move into the arterial side and therefore can go to heart, kidneys, lung, brain, etc. So everything that we do to help patients who have an ischemic stroke is all dependent on this thing called the penumbra. So every treatment that we give, the aim is to reduce the penumbra. So your penumbra is an area of brain tissue that is hypoxic or ischemic. It's not yet dead, but if you don't do anything about it, it's going to be pretty darn soon. So when you have a stroke, you have an area of necrotic core that starts. So you have an area that dies fairly quickly and it's dead, it's not coming back. And around that is this hypoxic zone. If you can unblock that clot really quickly, then that hypoxic zone can be salvaged and you can restore blood flow and it goes away. If you fail to unblock the clot, that hypoxic area over time becomes more hypoxic and basically adds to the size of the stroke, and you just get this growing of the size of the stroke. So if untreated, if stroke go untreated, this penumbral zone infarcts, dramatically increases the size of the stroke, contributes to a lot more brain tissue loss, which contributes to the level of disability. And in stroke, if a patient has a large vessel occlusion, so a clot in one of the main big vessels in the brain, for every minute that treatment is delayed, 1.9 million brain cells die per minute. So literally, time is brain when it comes to stroke treatments. So as I said, cellular death occurs over minutes to hours. So you'll have an area that starts immediately, but some of the area can hold on for a little bit longer. The area that dies is our necrotic core, and then surrounding this is this area of penumbra that's salvageable but hypoxic. So it's affected, it's not normal, but you can pull it back. So one of the tests that we commonly do in a lot of hospitals, not every hospital does this, but it's becoming more common, is a CT perfusion scan. So you're probably used to normal CT brains where it's literally an X-ray of the brain. You're looking at the integrity of the brain, very sensitive for seeing blood. It can show if there's big damage that's already been done to the brain from an ischemic stroke, we can see that. But it doesn't tell you the integrity of the blood vessel and the state of the actual integrity of the tissue itself. So sometimes we'll go on to do a CT angiogram where we give contrast dye, and then over time we can actually watch as that dye perfuses into those blood vessels, and you can see if blood stops and it doesn't go where it should, you know that that's where your blockage is. But to measure the core and the penumbra, we can then do a second contrast scan called CT perfusion or CTP. What this does is actually measures how long it takes for that contrast to actually perfuse into tissues. If it's taking a really, really long time, it means that something's happened, and usually a blockage, to say it's not getting in there as quickly as it should. So it's always about looking at the two sides, because the two sides should perfuse equally. So if we have a look at this first example, so remembering again that this is my right-hand side as I'm looking, so I'm looking from the patient's feet up, and this is my left-hand side of the brain. So in this case, the patient, you can see, has a really red-green area, and that's in their right middle cerebral artery. So that's a right middle cerebral artery stroke. So that's their penumbra. That's what's at risk if we don't unblock that clot. So they could lose that entire hemisphere. Middle one is a much smaller one, so that red-green area again, but now it's down the bottom, more towards the back area of the brain. And the last example is now in the left area, and it's actually probably our left motor strip in our frontal lobe. These scans are essentially the tale of two men who I nursed. So they came in with exactly the same story of sudden onset, remembering that the brain crosses over. So this is right middle cerebral artery, so it's producing left-sided symptoms. So they presented with left arm weakness, they had facial droop, they had slurred speech, but their language was intact because language is a left brain function, and this was occurring in their right brain. So they presented very similar stories. They presented much the same time. So here, if you have a look, there's a white circle around some red dots. That's likely the core. So that's likely already dead. So even if we unblock the clot this minute, chances are that area of brain's already gone, but it's fairly small. The green area that's now circled in red, you can see is much, much bigger. So this is this patient's penumbra. So if we don't unblock this clot, they're going to lose the green area as well as the red. If we unblock the clot, they're probably only going to lose the red. So patient number one, we managed to unblock his clot. We could give him clot-busting medication. And so that area that was red in that white circle, you can now see as a darker sort of grey-black area in the brain. So that's gone. But that green area survived. So he went home on day 3 with a little bit of a left facial droop, only slight slurred speech, but walked out very happy. Second patient, we didn't get to unblock his clot. He had a reason why we couldn't give him clot-busting medication, and therefore you can see just from that black area in that brain that's circled in red, it matches that green penumbra. So he lost the entire hemisphere and he passed away. So just to show the difference of what happens if we can fix that clot or not. So what are our stroke risk factors? Many patients cannot name stroke risk factors. If you say to them, tell me what you're at risk, what are the things you've got that put you at risk of stroke? They've got no idea. But if you say to them, name the risk factors for heart attack, they can list them. They know high blood pressure, cholesterol, obesity, they should be exercising, they should be watching how much they drink, all of those things. What they don't know is they're exactly the same. Vasculature is vasculature. So what is good for the heart is good for the brain. So all of those things need to happen, but people think about it in terms of heart only. So we need to educate them. So what are our risk factors for stroke? High blood pressure is absolutely a critical factor. In fact, it's the number one factor associated with stroke. So if all we do is make sure we get patients on antihypertensives who need them or optimize their antihypertensive, we're still winning. Heart disease is another risk factor. Atrial fibrillation is a massive risk factor. We know that atrial fibrillation can cause clots, which can obviously travel to the brain. Diabetes, smoking, obesity, high cholesterol, lack of exercise, being a bit of a couch potato, too much of the vino. Unfortunately, aging is a risk factor. Not a lot we can do about it. Obesity is a major issue. Obstructive sleep apnea has been shown to be a risk factor, and as has migraines, but particularly those migraines that have an aura. So the migraines that you get the flashing lights or the noise, etc., can be a risk factor for stroke. So these are the things we need to establish if our patient has them and then educate them on it. We usually break stroke risk factors down into modifiable and non-modifiable, meaning what can the patient do about it and what unfortunately is little to be done. So non-modifiable risk factors are age, sex, we can't change that. Familial history, we're born with what we're born with. If our family have given us dodgy genes, we can't really affect that. Race, unfortunately, as well, can be an impact on stroke. Now, you can see on the bottom of that list, I've got AF, diabetes and hypertension as a non-modifiable risk factor because it's actually in both columns. We'll talk about them in a sec. So modifiable risk factors is smoking. You can stop smoking. Alcohol, you can watch what you drink. Drug use, lifestyle. Now, AF, if you've got AF, you can't fix it yourself. You can't will it away. However, if you take the correct medication and look after yourself in every other way and do what's advised for your type of AF, you can mitigate the risk factor. So you can't remove it. It's not technically modifiable, but you can reduce it. Same with diabetes, same with hypertension. The number of people who have type 2 diabetes that can reverse that by doing all of those other modifiable risk factor reductions actually find that their blood sugar is much, much better controlled, and some even stop being labelled as diabetic. Same with blood pressure. You still may be technically hypertensive, but on minimal antihypertensives with really well-controlled blood pressure absolutely helps reduce your risk. The Stroke Foundation of Australia is an amazing resource, and I strongly urge everybody to jump online and have a look. They have two educational portals within their website. Inform Me is for health professionals and Enable Me is for patients. And you can give them to your patient and go through with them and actually identify all their risk factors. And then it gives you steps on strategies to actually reduce them. So this is, if a patient comes to hospital and you're looking after them with stroke, this should be part of their discharge planning. And that's all. Hopefully that's taught you something about stroke and it makes a little bit more sense because, as I said, unfortunately, we are going to see more and more patients having strokes, and they are just so devastating that we need to make sure that we recognise them, act quickly and treat them to reduce their levels of disability. Thank you.